Hey class, welcome to week 7 of lectures. This is our week of recorded classes, so we are now going to be going over the cardiac assessment lecture and the peripheral vascular lecture all in this one setting here. I'm going to show you where to get all this information from. We're going to go to our modules, and then if you will scroll down to module 3, whoops, I went too far. You'll see the Module 3 lecture materials. You can go ahead and click on that, and then click on the Health Assessment tab. And we're going to start off with the cardiac assessment portion first. I'm going to download it so it looks better on the screen for y'all. All right, so we're going to start with the cardiac assessment portion. This lecture is coming from your Essential Health Assessment book, Chapter 13, starts on page 220 and goes through page 239. Really essential for your cardiac assessment is you want to first start out by knowing your landmarks. Landmarks are going to be important not only for cardiac assessment, but also next week whenever we talk about respiratory assessment. So make sure you definitely know your landmarks. The first one that we're going to talk about is the MCL, or the midclavicular line. You have to find the clavicle, and then you split that right in the middle, and that is known as your midclavicular line. Your mid-sternal line is going to be an imaginary line that runs right down the middle of your sternum. And your anterior axillary line is going to be if someone was holding out their arm in a 90-degree angle, doing an imaginary line right down that armpit. That's going to be on the front. That's going to be your anterior axillary line. Manubriosternal angle, that's also called the angle of Louis. This is going to be important to note where this is whenever we start talking about listening to different heart sounds and lung sounds. So you really need to know where this is because it helps jumpstart you to know where to listen to those heart sounds. So your manubriosternal angle, or your angle of Louis, it's going to be at the level of your second rib. But how you get there is there's a little hole fill-in thing in your throat. If you'll feel where that is, right beneath it is a flat piece of bone. So you're going to walk your hands down that flat piece of bone until you feel that little ridge. And that little ridge right there, if you go out to the side, there should be a rib that connects with it, and that's your second rib. So that little ridge is known as your manubriosternal angle. And this is important because your cardiac sounds, or your heart sounds, we start listening to them at that space underneath that second rib. So it's very important to be able to locate that second rib, and that manubriosternal angle is important as well. Your intercostal spaces, we'll also be referring to them as ICS. That's just the little spaces that are in between the ribs, and each of those is named for the space above it. So like if the space beneath the second rib, that's going to be your second intercostal space. On exam 2, we're not going to be able to just point and ask you, where is this heart sound located, or point to this. You're going to have to know this terminology and know how to use it on an exam as well. Out of the way here. That's bothering me. All right, so this is just a picture reference of where these landmarks are on a body, so you can kind of get a visual of where that mid-sternal line is, the mid-clavicular line, the anterior axillary line, and then just some different cardiac anatomy pieces that you're familiar with, like the left and right atrium, left and right ventricle, to kind of give you a reference point of where all these things are. So, cardiovascular system. Your cardiovascular system consists of your heart and your blood vessels. Remember, your heart is that little hollow muscular organ that's about the size of a closed fist, and your heart extends from that second to the fifth intercostal space. Then you've got your blood vessels. You've got your arteries, your capillaries, and your veins. Remember, your arteries carry blood away from the heart. They carry that oxygen rich blood from the heart to the rest of the body. And then you have the capillaries, which is where the exchange of the fluid, the nutrients, and the metabolic waste between the blood and the cells happen. And then you have the veins, which carry the blood toward the heart. Most of these carry your oxygen depleted blood back to the heart. There is an exception with your these rules with your pulmonary artery and your pulmonary vein, but for the most part, your veins carry blood toward the heart, and your arteries carry that blood away from the heart. Precordium. All right, so this is that imaginary box where the heart and the great vessels sit. So whenever you're thinking about the heart, you can kind of think of it as like an upside down triangle. And we're also going to be talking about an apex and a base of the heart. A lot of people think that an apex is the top part of something and the base is the bottom part of something, but that's not necessarily true. And it's definitely not true whenever we're referring to the heart. Okay. The actual definition of an apex is going to be the narrowest point, and the definition of a base is the widest point of something. So whenever we're talking about the heart, the apex of the heart, that's the narrowest point of the heart. So it actually, as you can see in this picture, is down there at the bottom. And you're going to want to make note of where exactly this apex and this base are located. Um, so you're going to want to jot down this right here. Your apex or your narrowest point of the heart, that's going to be at your fifth intercostal space, left midclavicular line. The apex of the heart is at the fifth intercostal space, left midclavicular line. The base of the heart, which is the widest point of the heart, is going to be at the second intercostal space on the right and left sternal borders. Second intercostal space on the right and left sternal border. If you need an outside visual landmark of where things should be positioned, the fourth intercostal space is usually going to be around the nipple line. So that fifth intercostal space, most of the time, is going to fall to about where an underwire of a bra would be. That just kind of gives you a visual reference of where it should be. Some just to kind of jog your memory, some internal anatomy of the heart. You may need to review this if you're unfamiliar or if you've forgotten like where your major cardiac structures are. We're going to come back to this picture in just a second, but I want to go to this slide first. Let's talk about the direction of blood flow in the heart for just a second, and then we'll go back to that previous slide. So the direction of blood flow in the heart, you have the deoxygenated blood that comes from the body, and then it goes through your superior vena cavas, then your right atrium, your tricuspid valve, your right ventricle, your pulmonic valve, your pulmonary artery, and then your lungs. And whenever that deoxygenated blood gets to the lungs, that's where it picks up its oxygen And now that oxygen-rich blood goes through the pulmonary veins, then the left atrium, then the bicuspid or the mitral valve, the left ventricle, the aortic valves, the aorta, and then out to the systemic circulation. Um, the way that I kind of remember some things about the blood flow in the heart, I think of like AV valves. So the tricuspid is an AV valve, and the bicuspid or the mitral valve, that's an AV valve. And the blood flows through them. It goes to the atrium first, AV valve, and then ventricles first. So the AV valves are between the atrium and the ventricles. I remember PAL, PAL, for remembering that the blood passes through the pulmonary artery and then the lungs. And I remember if I'm shopping, I like to try on clothes before I buy them. So blood flows through the tricuspid valve before it flows through the bicuspid valve, right before you buy. That's how I remember that. So basically, if you think about it, the right side of your heart gets your deoxygenated blood and it carries it to your lungs, and the left side of your heart gets your oxygen rich blood and carries it out to the rest of your body. Then, once it reaches your body, it just starts that cycle all over again, kind of like a continuous loop. So, now let's go back to this previous slide and let's talk about this picture for a minute and see why this makes sense. So if you can look at the pink right here, that is the muscles that are in the ventricles, and you can see that there's more muscle over here on this left side. Why do you think that is? Well, that makes sense if we know the direction of blood flow in the heart, because it takes more effort to move that blood from your heart to your toes. So your right side is going to be more responsible for only getting blood to your lungs. So that's why it doesn't require as much muscle. Okay. Another key thing to note about your heart is how it's positioned in your body. It's positioned to where more of the left side is kind of tilted in toward the inside of your body. So, why is this significant? Because from what we just learned about the blood flow of the heart and the jobs of each side of the heart, we know that the left side essentially is the more important side because it, remember, it pumps blood out to the body to keep you alive. So if you have like blunt chest trauma, it's protected more just because of its natural anatomy inside of you. So I think that's pretty cool to think about whenever you're thinking about the heart. This is just a little visual. If you needed a little picture to remind you of the direction of blood flow in the heart, you can look at that right there. The heart also has different layers. You have the endocardium, which is your innermost layer of the heart. You have your myocardium, which is that middle muscle layer of the heart. And then you have the epicardium, which is that outermost layer of the heart. The heart is going to be housed, and you can see it in this picture. It's housed in a little sac called the pericardium. So between the epicardium and the pericardium, you have this lubricating fluid because the heart moves a lot and you want frictionless, painless movement every time that heart beats. So that fluid helps that. And then the pericardium is kind of like a little Ziploc baggie that holds the heart. I don't know if y'all have ever heard of the medical condition pericarditis, but whenever someone has pericarditis, that's actually inflammation of that little sac, that little Ziploc baggy thing, and you have pain with every heartbeat. Okay. Now, somebody that's got something opposite of that, which is endocarditis, that would be on this inner layer of the heart, and that's kind of harder to get to than pericarditis, but both are not enjoyable, that's for sure. All right, the heart valves. With the heart valves, we have the atrioventricular or the AV valves, which is our tricuspid and mitral valves. And then we have the semilunar valves, which are our pulmonic and aortic valves. Our heart valves, their main purpose is to prevent the backflow of blood. So all the blood going through these valves should be unidirectional, which means that it should only open one way, let blood through, and then close. So it opens and it closes passively in response to pressure gradients in that moving blood. So how I remember which is which, AV, you just have to remember tricuspid and mitral valve, but semilunar valves, I remember that by SLAP. So semilunar is the S and the L, and then the A is aortic and the P is pulmonic. So that's how I remember which ones the semilunar valves are. The cardiac cycle, that consists of something called systole. That's the period where the heart is contracting and it's sending blood on its outward journey. And diastole, that's the period when the heart relaxes and fills with blood. There's a pretty cute little video. You've got the link here on your PowerPoint slide, so you are more than welcome to play that. I may be able to play it on this. Oh, yeah, it is going to let me.
For nearly 50 years, Harbor Freight has been a reliable source for the widest variety of tools.
Ventricular contraction causes the atrioventricular valves to close, which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole. Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atria, the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling. The atria then contract and complete the ventricular filling.
All right. So that kind of gives you an idea about how the cardiac cycle works. So heart sounds, S1 and S2. So if everything sounds normal, so if you're listening to a heart and you hear lub dub, lub dub, lub dub, that's normal. Okay. So we would chart that as S1 and S2 present. So what all those mean? The lub in that is S1. Okay, and that's associated with closure of those tricuspid and mitral valves. And then the dub, or the S2, that's associated with closure of the pulmonic and the aortic valves. So during systole and diastole from the previous video, it talked about when those semilunar valves and those AV valves close during the cardiac cycle. And that's what causes those sounds. So instead of thinking of lub dub, you could think of AV valves closing, semilunar valves closing. AV valves closing, semilunar valves closing. So when you document, again, for normal heart sounds, if everything sounds normal, lub dub, lub dub, lub dub, you document that as S1 and S2 noted. Now, other heart sounds that you may hear, one of them is a splitting of S2, and this is when more pressure builds up to that right side of the heart, and there's less pressure on that left side of the heart, and the sound that's produced sounds like lub ta dub, lub ta dub. You should only hear this sound on deep inspiration. So if someone has this, you may not hear it with every heartbeat. It's only going to be with that deep inspiration that it happens. And this is a sound that you shouldn't hear, but if you do hear it, you need to see whether or not your patient is doing it intentionally or unintentionally. If they're not holding their breath or, really taking a deep breath in and making themselves do this heart sound, then it's pathologic or it could be caused by a disease process somewhere. But you can actually make yourself create this extra heart sound. If it's done on purpose, if somebody's just doing it on deep inspiration on purpose, that's known as a physiologic splitting of S2. So that's not pathologic, it's not bad. That's the only time really when we consider that normal. But if it's occurring not with intentional deep respiration, that's when it becomes a problem. So, how this sound creates itself, it creates by the aortic valve closing just a little split second before that pulmonic valve closes. And they should be closing at the same time. Let's see. Yeah, I already told you all that, so that's good. All right, extra heart sounds again. There's some that's called S3 and S4, so you may hear some of these whenever you're listening to the heart. S3 and S4, they're called gallops because they actually sound like horses galloping. Okay. S3, a lot of the times people say it sounds like Kentucky, Kentucky, Kentucky. S4, people say sometimes that sounds like Tennessee, Tennessee, Tennessee. Um, S3 is heard in early diastole, so that's when those ventricles are filling up really rapidly. And usually it's associated with left ventricular failure, if you hear that. Now, whenever you hear S4, that's heard in late diastole, and that's usually associated with something resisting that ventricle filling. So, something like hypertension or coronary artery disease, a lot of the times will cause those S4 heart sounds. Now, S3 can be normal in physically active young adults, but if you ever hear it in a patient that's older than 40, then we want to consider it abnormal and it's usually associated with heart failure. This is the order that you would hear these abnormal heart sounds in if it was on a continuous loop. You don't want to think of this as being in a straight line. You want to think of it as being on more of a continuum, with S1 being the start of systole and S2 occurring at the very end of systole. So if you had an S3, you would hear that in early diastole. And if you had an S4, you would hear that in late diastole, right before S1. All right, so let's talk a second about murmurs. Murmurs are going to be produced by turbulent blood flow. We grade these murmurs on a scale of 1 to 6, and we'll talk about those in just a second. If you do hear a murmur, it's very important to document the timing that it's happening in the cardiac cycle, to document its quality, its pitch, its location, and its intensity. And in your book, on page 232, there's a table, table 13-1, and it talks about the different murmur grades, their numbers, and a description of what those numbers are. But we're going to listen for these sounds with the bell of our stethoscope, and it's going to sound like a swish. Now, it's never really sounded like a swish to me. For some reason, it sounds more like a busted speaker. But whenever you hear one, you can decide for yourself what it sounds like. And we'll be setting up our little auscultation mannequins this week in lab and letting you listen to a murmur, and you can hear what that sounds like. Remember, the valve's job is to direct traffic and prevent backflow. But whenever you have a valvular problem, the valves don't close like they should, and blood backflows, and that backflow is the swishing sound of a murmur. So we already talked about up on the slide here what to document and what to pay attention to if you do hear a murmur. And then the different grades. I'll kind of mention briefly what they are, but you can look in the book as well. Grade 1 would be barely audible. Even to the trained ear, that's going to be really hard to hear. Grade 2 would be clearly audible. Grade 3 would be moderately loud. Grade 4 would be loud with a palpable thrill, and we'll talk about what a thrill is in just a second. Grade 5 is very loud with a palpable thrill, can be heard whenever the stethoscope only has partial contact with the chest. And a grade 6 is extremely loud with a palpable thrill, can be heard with the stethoscope lifted just off the chest wall. Don't get bruit and murmurs confused. They sound a lot alike, but remember, bruits are heard whenever we place the stethoscope over an artery. Murmurs are heard whenever we place our stethoscope over a valve. So there's going to be systolic murmurs that are going to be heard during systole and diastolic murmurs that are heard during diastole. If it's a systolic murmur, you're going to hear the swishing sound in between the lub and the dub. If it's a diastolic murmur, you're going to hear the swishing sound after the dub. So timing kind of determines whether this murmur is bad or if it's okay. So if you think about it, the worst of the two would probably be a diastolic. And the reason being is if it's a systolic murmur, remember what's going on during systole, those ventricles are working hard and they're squeezing. So that's really not as bad as hearing a murmur during diastole. Diastole is supposed to be when the ventricles are relaxing. So if we have backflow of blood whenever those ventricles are relaxing, that would be more concerning. So lub dub swish is bad every time you hear it. So training your ears to know the difference. These are the sounds that I really want you to get good with and focus on, and that's going to be S1, S2. That's normal. I want you to be comfortable hearing S3, S4, the splitting of S2, murmurs, and you also have an online resource through your F.A. Davis online resources, and there's a little section under there that's called interactive resources, and you can listen to the different heart sounds that I'm talking about up there so you can start to train your ears to know the difference. Also, your shadow health assignments this week, there's a cardiac concept lab, and it walks you through different examples of these as well. And then I've also listed an extra web link resource for you down there that you can click on and listen to the different sounds to get to know the difference as well. All right, so the conduction system. So we've already learned that contractions of the heart occur in a rhythm called the cardiac cycle, but it's also important to note that these contractions are regulated by impulses that normally begin at the SA node, which is the electrical activity of the heart. Okay, and you'll go into more detail in later semesters about this, but that is what actually produces the waveforms that you see on EKGs. All right, so cardiac output. This is really the absolute bottom line for assessment of the heart is going to be your cardiac output because this tells you the amount of blood that the heart pumps out in 1 minute. What would be normal is usually about 6 liters per minute. So it really tells you how much blood is being pumped out to the body. So when it's all said and done, this little value right here of cardiac output tells you how effectively the heart is working. So there's a little formula that you will learn that's heart rate times stroke volume. But you won't need to calculate that for 112, but you'll probably hear that in your later semesters about how to calculate cardiac output. All right. We also have vessels in our neck that are important for cardiac assessment. So this is just a picture showing your major neck vessels, which are your carotid arteries and the jugular veins that you see right there. You need to know where these are because we'll be talking about ways to assess these in just a minute. And this is just an anterior view of those major neck vessels as well. So with the different neck veins, these are the two main ones up here. The carotid artery, that's your central artery, and it's timed with ventricular systole. So every time your heart beats, you feel a pulse here in that carotid artery. Your jugular veins, you have internal and external jugular veins, and there's no cardiac valve between the vena cava and the right atrium. So these jugular veins give you great information about right-sided heart activity. All right. This just shows you the position of the heart in an infant and a child. With an infant, their body's smaller, so their heart's smaller. It only goes down to about the fourth intercostal space. But by the time that they're a child, the heart goes down to the normal position, which is at the fifth intercostal space. Things to note about the aging adult, how the heart works, and heart health of an aging adult is greatly influenced by someone's lifestyle, um, growing up, smoking, diet, exercise. Blood pressure usually increases with age. Those arteries start to stiffen due to arteriosclerosis, and the left ventricle thickens up due to just increased workload over the years. You also start to see more arrhythmias and ECG changes as the adults age as well. Blood pressure and pulse are another important part of the cardiac assessment. So make sure you go back and review about blood pressure and pulse from your vital signs lecture. All right, now we're going to talk about where the different heart valves sit. And this is important because these are the 5 locations where you're going to be placing your stethoscope to listen to heart sounds. So if you'll notice up there on that picture, you have 4 heart valves that are listed. And you also have something labeled as Erb's point. Okay, Erb's point is not a heart valve, but that's just the place where all heart sounds are heard equally. So we're going to make sure that we put the stethoscope there as well as over our 4 heart valves whenever we're listening for heart sounds. So it's very important to note the specific location of where each of these little 5 points are. So the aortic area is going to be at the second intercostal space, right sternal border. Your pulmonic area is going to be in the second intercostal space, left sternal border. Your Erb's point is going to be in the third intercostal space, left sternal border. Tricuspid is going to be in the fourth intercostal space, left sternal border. Now, some sources will say that the tricuspid is in the fourth or the fifth intercostal space, but for testing purposes and for 112 purposes, we're going with your textbook, and it actually says fourth intercostal space, left sternal border. So that's what we're going to be going with for the tricuspid area. And then, last but not least, you have the mitral area, which is also known as the apical area, and that's going to be at the fifth intercostal space, left midclavicular line. So important to note all those. And how we get there is that little hole that I was talking to you about earlier, that's right there above your sternum, right in your throat, is what it feels like. That hole is called the suprasternal notch. So you start there and you walk your hands down to that flat bony piece, and then there's a ridge right there. That's your angle of Louis. And then you go out from that ridge, and you should feel a rib, and that's your second rib. So if you go to that space right below that second rib, that's that second intercostal space, and that's where you start with your cardiac landmarks, listening with your stethoscope. Now, a good way to remember this, a saying is all positions earn their money. My favorite saying is a pet monkey, just to remember the different names and locations of the different where the different heart valves and stuff sit. So you can kind of walk yourself through each area and kind of learn where those different positions are. Some people have more breast tissue than others, so just kind of be mindful whenever you're displacing breast tissue to use the dorsal side of your hand rather than the palm side of your hand whenever you're moving breast tissue. All right, so cardiac review of systems. Let's see. We're going to start with family history. So, with cardiac issues, there are familial tendencies. So, cardiac issues do seem to be genetic. So, if someone in your family, like a first degree relative, has had cardiac issues, there's a good chance that you might also develop cardiac issues in the future. Rheumatic fever is something that we will check for. That's just an inflammatory disease that can damage the heart and the heart valves. So we really want to get a good medical history about that. Any parents or siblings die of a heart attack, that gives you an increased risk, especially if your father or your brother had a heart attack before the age of 55, or your mother or your sister had a heart attack before the age of 65. That puts you at an increased risk. Um, Medication history, I want to know what medications you're taking for your heart. Why are you taking them? Any side effects that you're having. Health promotion, we want to try to promote a heart healthy diet. That's your fruits, your veggies, your whole grains. You want to decrease cholesterol diet. You want a diet low in saturated and trans fats and low in sodium as well. Alcohol, we really want to educate our patients on the risk of excessive alcohol. Those are just correlated with heart failures, increased blood pressure, cirrhosis of the liver. So we want to discourage excessive alcohol as much as possible. Exercise, we want to promote exercise. This is how I kind of think in my head whenever I'm thinking about why cardio exercise is so important. I think of arteries kind of like a water hose. So if you leave a water hose just barely trickling, and then you just leave it there and don't do anything with it, what happens to the pipe? It gets this yucky buildup on the inside that makes that lumen smaller to get that water through. But if you turn it on high and you have that water, which is simulating, in my mind, blood flow, putting a pressure force through that pipe, it helps clean out the bad stuff, and it's going to help keep that atherosclerosis from accumulating in that artery. Current health status, I want to ask about these specific things like chest pain. I'm going to be going through my old card. Heart palpitations, that's kind of like a fluttering in the heart or the heart racing. That's usually related to some sort of irregular heart rate. Cardiac abnormality, fear, stress, anxiety could cause heart palpitations. I want to be alert to any type of color changes, especially on the skin or the lips. The specific color I'm looking for is signs of deoxygenation, like that gray or that blue look. Shortness of breath, That's what dyspnea means, a shortness of breath. So I want to go through my old charts with that. Any type of edema or swelling, I want to ask about that. Nocturia, that's excessive urination after going to bed at night. That can indicate some fluid buildup. So I want to ask questions about that. And I also want to ask questions about fainting, any loss of consciousness that can be associated with cardiac arrhythmias. So, inspection and palpation of the cardiovascular system, overall view of skin color, hair distribution, edema, abnormal pulsations. I am looking at capillary refill time. I'm palpating pulses. I'm palpating to see whether or not there's a thrill, and I'm inspecting or I'm looking to see whether or not a heave or a lift is present. So if I see an abnormal pulsation, I'm automatically thinking aneurysm, so I want to be really careful if I see a really big bounding pulsation around the heart. Capillary refill, that's where we're just going to press down on that nail bed, and that nice pink color is going to go away for a second. But whenever we let go, that nice pink color should return pretty briskly. We like for it to return back within 3 seconds. That's called a brisk capillary refill, and that's associated with good circulation. Um, with a thrill is something that we palpate. So there's specific areas on the chest where we'll place our palm. There's actually 3 different areas. I'll show you all that in a minute. But we're feeling for like a vibration on our hands. So it almost feels like whenever you've touched a cat's belly and it's purring, that little vibration feel, that's what a thrill feels like. If you feel a thrill, whenever you're palpating the cardiovascular system, that's associated with a grade 4 murmur or higher. Now, a heave or a lift, that's going to be something that you see. And we usually assess for these by looking at that apical area, which is that fifth intercostal space, left midclavicular line. And it's just a pulsation that you see, and a little bit of a pulsation is okay. So it's okay if it's less than the size of a quarter. But if it's something that's greater than the size of a quarter, then we call that a heave or a lift. And that would be associated usually with hypertrophy of the heart, which is an enlarged heart, or cardiomegaly, which also means an enlarged heart. Now, you may see a little heave or a little lift that's not quite the size of a quarter on babies or really thin individuals, or maybe after somebody's got done exercising, but it never should be greater than the size of a quarter. Auscultating the carotid artery, you're going to auscultate the carotid artery on patients that are middle-aged or older who show signs and symptoms of cardiovascular disease. So anybody middle-aged or older coming in with chest pain, shortness of breath, fatigue, palpitations, dizziness, lightheaded, anything in that category, we're going to go ahead and auscultate that carotid artery. We're going to listen with the bell of our stethoscope, and we're listening for a bruit to see if there's any stenosis or plaque buildup in those arteries in the carotid space. Also, y'all don't know this yet because you haven't had your respiratory lecture yet, but that's also where our loudest breath sounds are. So we're going to get our patient to hold their breath as we're listening over the carotid artery so we don't confuse anything. You'll see the 3 oscillatory areas on this picture for you. We want to make sure that we listen at the angle of the jaw, at that mid-cervical area, and at the base of the neck. Palpating the carotid artery, we're going to do this gently because we don't want to stimulate that vagal nerve, that cranial nerve 10 too much. And also, we're going to palpate one at a time because these are arteries, so they are carrying blood away from the heart. So this is actually carrying that blood towards the brain. So if we occlude both sides at the same time, then there's no blood flow getting to the brain, and our patient will pass out on us. All right, inspecting the jugular venous pulse. This actually judges the heart's efficiency as a pump. We're going to position our client in a supine position, 30 to 40 degree angle, but you don't want to put a pillow underneath their head. You want to remove that pillow to avoid flexing of the neck. And you're going to stand on the person's right side because the veins there have a direct route to the heart. So that's really what we're wanting to see. You can direct a little light across the patient's neck whenever their head's turned. And then you're going to hold a vertical ruler on that sternal angle and measure the level of pulsation. What we want is less than 2 centimeters. That would be considered normal. And I'm going to show you a little video of how that's done.
Getting your flu shot at CVS matters because we'll work around the most important schedules. Yours.
Hi, my name's Zach. This is Harrison. Today we're talking about measuring jugular venous pressure, or JVP. So let's get right into it.
We'll assume for today that you've already washed your hands and consented the patient. Begin with your patient at 45 degrees. This is especially important, as you'll soon see. Ask them to look away from you, up to their left, and try to make out a pulsation in their internal jugular vein, which is located between the sternal and clavicular heads of the sternocleidomastoid muscle. However, the pulsation is difficult to see and may not even be visible in a healthy patient. The important thing is to differentiate it from the carotid pulse. Unlike the carotid pulse, the JVP is non-palpable and consists of 2 beats per cardiac cycle rather than 1. If you're uncertain, you can apply gentle pressure to the abdomen to see if the JVP rises as a result of the abdominal jugular reflex. If the JVP is visible, its height is measured from the sternal angle, perpendicular to the ground, as demonstrated here. The JVP gives an indication as to the pressure in the venous system. You can think of it as the column of blood waiting to fill the right atrium from above. The higher the column, the higher the pressure. The JVP is a particularly complex and difficult topic, but learning to identify a raised JVP is a good first step.
Remember, this is one of the trickier elements of the cardiovascular exam. Keep looking and comparing your findings with those more experienced than you. As with everything, it gets easier with time.
All right, so that's how you measure that jugular venous pulse. All right, palpating the apical impulse. In the past, this has been called the PMI, or point of maximal impulse. So you may hear it called both ways. You may or may not be able to see it, and this is going to be the area where you might see that heave or that lift. Sometimes if you turn your patient and you position them on their left side, that can help you better palpate this area, just because gravity will help you out. Palpating across the precordium. This is what I was talking about with palpating across the chest earlier. There's going to be 3 different places where we're going to place the palm of our hand, and that's going to be at the apex, which is that 5th intercostal space, left midclavicular line. We're also going to place our palm on the left sternal border, and then again at the base, which is the base is that 2nd intercostal space. So this is where you're going to palpate to feel for those thrills. Like I said, we're going to use the palm of our hand, no fingers, just palm. And if we feel a thrill, then that is associated with a grade 4 and above murmur. Auscultation of the heart. What we're going to do first is we're going to listen in all 5 of those oscillatory areas with our diaphragm. And then we're going to go back and listen to all 5 of those oscillatory areas with our bell. Okay. Big thing that you need to concentrate on whenever you're listening to heart sounds is identifying that S1 and S2. Once you've identified S1 and S2, then you can figure out if anything else is abnormal in there. But it's very important first to hear those 2 normal heart sounds of S1 and S2 before you can identify anything else. If you're having trouble with distinguishing which one is S1 and S2 or whatever, then you can always, while you're listening, go up and palpate the carotid artery, and that carotid pulse against your fingers, that's your S1 or your lub. Whenever we're listening with the bells, we're trying to pick up for murmurs. And of course, you're going to need to be able to distinguish between S1 and S2. So if you hear a murmur, you're going to know whether it's diastolic or systolic. And this comes with practice, just like anything else. This is just another visual picture of you to know where you need to place your stethoscope in each of those 5 areas. They're going to generalized areas in the future, but for right now, I would just keep it at these pinpoint areas the traditional way for now. So whenever you're auscultating at the apex, if you think about your cardiac anatomy, this makes sense. S1 is going to be heard loudest at the apex, and that makes sense because S1 is whenever those AV valves are closing. That's what's making that S1 sound, is AV valves are closing. And whenever we reviewed the anatomy of the AV valves, they were located more toward the bottom of the heart. So remember that apex of the heart is located at the 5th intercostal space, left midclavicular line. So it makes sense that at the apex, we would hear S1 the loudest. Just like it makes sense when we're auscultating at the base, S2 is going to be heard at the loudest because that's where those semilunar valves are located closer to, and that's what's going on during S2 is those semilunar valves are closing. This picture right here just shows a practitioner auscultating heart sounds. Some heart sounds are heard better in this position because gravity can kind of help those heart sounds become more clear if your patient is sitting up and leaning forward. We can't talk about the heart without talking about heart failure. You will see patients, even in your 112 clinical, every single day that has congestive heart failure, no matter what floor you're working on. So this is just a couple of the highlights that I want y'all to know about heart failure. There's 2 types, there's right and there's left, and you need to be able to identify at least 2 symptoms of each. So with right-sided congestive heart failure, the main things that you will see is jugular vein distension and systemic edema. So the right side of the heart, remember that pumps blood to the lungs. So if that's not working effectively, blood's going to start to back up, and the first place that you're going to see it is in those jugular veins. Left-sided congestive heart failure, the big things that you're going to see is pulmonary edema and a frothy pink sputum cough. Left-sided congestive heart failure, this is a little more serious because this side's going to be responsible for getting the blood to the rest of the body. So pulmonary edema, that symptom comes from blood backing up into the lungs, and that makes the lungs start to sound wet. That pink frothy sputum cough, that's because you now have this blood backing up into the lungs, which the lungs see as a foreign object because it's not supposed to be in there, and that makes the patient cough. So it's a red pinkish color because it's blood mixed with sputum. And frothy just means like foamy. Treatment with congestive heart failure, we treat the symptoms. There's no cure. These patients will be on diuretics like Lasix. They're in and out of the hospital. So these are your frequent flyers that require a lot of care. Some blood work tests that you're going to see done to assess the cardiac system. You have the lipid profile, and that consists of a total cholesterol level, a low-density lipoprotein, a high-density lipoprotein, non-HDL cholesterol, and triglycerides. So a lipid profile, that's just a blood test that measures the levels of various fats or lipids in your bloodstream. Patients need to fast 9 to 12 hours prior to having a lipid panel drawn. Cholesterol, that's that waxy fat-like substance that's carried through the bloodstream. So total cholesterol levels are just a measure of the different types of cholesterol in the body. Your low-density lipoproteins, or your LDLs, this transports your cholesterol from the liver to the walls of your blood vessels. So this is known as the bad cholesterol because it's the cholesterol that builds up in your arteries. So you want that number to be low. Your high density lipoproteins, that transports your cholesterol from your tissues back to your liver, where it's broken down and eliminated from the body. So that's known as the good cholesterol. You want that to be high. Your non-HDL levels, that's just your total cholesterol minus your HDL cholesterol. And your triglycerides, that's just the end products of your fatty foods. It's a good idea to go ahead and start looking at normal and abnormal values for your labs. So your normal and abnormal cholesterol levels, you're going to find those in your book on page 234. There's a table, table 13-2, and you can look at those normal and abnormal cholesterol levels. Creatine kinase bands, or MB bands, these are your creatine kinase myocardial bands, specific because it has the MB there on the end. This blood test will be elevated whenever cardiac tissue is damaged due to decreased oxygenation. So we may draw these levels if we suspect that something has happened where there might have been damage to the heart, like a heart attack or something. Troponin level, that just measures the levels of proteins in cardiac muscle, and these proteins are released whenever there's heart damage. So whenever there's damage to the heart, this value is going to increase. Some other diagnostic tests that assesses the cardiac system, an electrocardiogram, we call this an EKG or an ECG, either one. This records the electrical activity of the heart, and it helps diagnose abnormal heartbeats, heart rhythms, and tissue ischemia. An echocardiogram, sometimes you'll just hear this called an echo. This is where we use a transducer and which creates these sound waves, and those are sent to a computer that shows moving images of the heart walls and the heart valves, and it helps to diagnose things like congestive heart failure, enlarged heart, and aneurysms, things like that. The Holter monitor, that's where a patient wears a little small portable monitor for a couple of days, and it records the patient's heart rate and rhythm, and it's then analyzed by a cardiologist. Exercise stress test, that's where the patient is hooked up to an EKG while walking and running, and then the healthcare provider monitors the patient's heart function and rhythm as they're doing this. All right, a little more detailed look at the EKG. There are different kinds of EKGs. You have a 3-lead, a 5-lead, and a 12-lead. The 3-lead EKG, that uses 3 electrodes, and they're used primarily for your basic monitoring, such as emergency settings or during transport. Your 5-lead EKG, those uses 5 electrodes, and that's used primarily in telemetry settings whenever we need continuous monitoring. And a 12-lead EKG, that uses 10 electrodes, and that's your standard just one-time shot for comprehensive cardiac evaluation. It gives the most detailed analysis for that specific moment in time, so it can just take a picture of that specific moment in time. Nurses need to know how to connect the electrodes and the leads and where to place them for each of the different EKGs. I'm going to let y'all watch a couple of these videos so you can kind of understand what I'm talking about. The first one's going to be a 3-lead EKG, preparing the patient for it.
What's that called, Mom?
Vitiligo. Curiosity is a question at the edge of every thought.
So if you're looking...
Lead placement. In this module, we will be looking at a 3-lead, 5-lead, and a 12-lead system, and their paperwork that you would get with them. The 3-lead system. Notice how I've got the heart positioned in the chest here, and this is to highlight the information we've covered in our anatomy and physiology section. This is influencing why we put the leads where we do. We have our white lead, which goes to the right upper chest, and it sits just under the clavicle and in the soft tissue space. The black lead, which sits in the left upper chest, again, just under the clavicle in the soft tissue space. And then the red lead, which sits at the lower part of the ribs or just under the ribs. Now we have a saying to help us remember our placement, and that is white to the right and smoke over fire. Now you'll notice this triangle. This is Einthoven's triangle. If we go back to that history lesson we had on ECGs, he was able to identify that this 3-lead placement will actually give us many views of the heart. Particularly, we're going to be looking at lead 2, and we'll come back to this paperwork and the leads that we're going to see in a few minutes. Now, if we're doing a 5-lead system.
Okay, and I actually like this other video better for a 5-lead. So I like that one for the 3-lead, but we're going to watch this one for the 5-lead.
This memory trick makes it so easy to remember how to place a 5-lead ECG, so let's get right into it. Welcome to the channel where medical topics are made easy. This video will show you how to place a 5-lead ECG for cardiac monitoring and telemetry. And we're going to use a mnemonic and memory tricks to remember exactly where to place the electrodes and leads. You're going to remember the following phrases: white on the right, clouds over grass, smoke over fire, and I heart chocolate. These phrases will coordinate with the colors of the leads. So what does this mean? Well, let's quickly look at what these colors are referring to. In order to obtain a 5-lead ECG, electrodes are placed on the skin. Electrodes are sticky pads that are placed on the body in certain positions. The electrodes allow the electrical activity of the heart to be recorded. The lead wires are wires that are connected to the electrodes, and they transmit the heart's electrical activity to the ECG machine. Each of the lead wires are different colors and need to go in the correct position, and that's where the memory tricks come into play. So a 5-lead ECG uses 5 electrodes and 5 color-coded lead wires. The circles are the electrodes, and the colors are the color-coded lead wires that attach to it. First we have the white lead, which is the right arm lead. Then we have the green lead, which is the right leg. Next we have the black lead, which is the left arm. Then we have the red lead, which is the left leg. Finally we have the brown lead, which is the chest or V1 lead. Now let's look at the memory tricks to remember where the colors go. The memory trick we're going to walk through is white on the right, clouds over grass, smoke over fire, and I heart chocolate. Let's go through these step by step and talk about exactly where to place the electrodes and lead wires. Starting with white on the right, this will help you remember the white lead goes on the right side. The white lead is the right arm lead, and you will place the electrode below the right clavicle at about the second intercostal space, mid-clavicular line. Next, you'll remember clouds over grass. This will help you remember the white lead, which is clouds, goes over the green lead, which is grass. The green lead is the right leg lead, and you will place the electrode on the lower edge of the rib cage at about the 7th or 8th right intercostal space, mid-clavicular line. Next, you'll remember smoke over fire. This will help you remember the black lead, which is smoke, goes over the red lead, which is fire. The position is the same as what we just did on the right, but now it's on the left. The black lead is the left arm lead, and you will place the electrode below the left clavicle at about the second intercostal space, mid-clavicular line. The red lead is the left leg lead, and you will place the electrode on the lower edge of the rib cage at about the 7th or 8th left intercostal space, mid-clavicular line. Finally, you'll remember I heart chocolate. This will help you remember the brown lead, which is chocolate, goes in the center of the chest by the heart. The brown lead is the V1 or chest lead, and you will place the electrode in the 4th intercostal space, just right of the sternum. A 5-lead ECG is typically used for cardiac monitoring or telemetry, as it provides a continuous live reading of the electrical activity of the heart. In other words, a 5-lead ECG is used when a patient's heart rate and rhythm must be continuously monitored, such as in the hospital or emergency room. A 5-lead ECG differs from a 12-lead ECG in that it provides continuous monitoring of the heart, whereas a 12-lead ECG provides a static, more comprehensive reading of the heart at that specific time. Hopefully this helped you understand how to place a 5-lead ECG. Please share this video with others and hit that like button and leave a comment. Subscribe to Save Time Study.
Okay, so that was your 5-lead. And this is preparing the patient for a 12-lead.
One of these lunches has a peanut lover's favorites. The other has a sunflower butter you packed for your son. You do your best to help them avoid food allergens, but
Welcome to the channel where medical topics are made easy. This video will explain how to place a 12-lead ECG and its electrodes. We're going to use a mnemonic that makes 12-lead ECG placement easy for EMTs, paramedics, nursing, and more. So let's get right into it. A 12-lead ECG uses 10 electrodes, which are the sticky pads placed on the skin. Be aware that electrodes and lead wires are not the same as leads. So many people get this wrong, and we're going to explain this in a minute, so keep watching. This will also explain why a 12-lead ECG uses only 10 electrodes. So again, a 12-lead ECG uses 10 electrodes. These 10 electrodes can be divided into two types, the limb electrodes and the precordial electrodes. The limb electrodes are placed on the extremities, and there are 4 of them. And the precordial electrodes are placed on the chest, and there are 6 of them. So what exactly do all these circles and colors represent, and what do all these definitions mean? We're going to go back to this diagram in a minute. But first, let's clarify some definitions because a lot of people get this wrong, so do not skip this part. In order to obtain a 12-lead ECG, 10 electrodes are placed on the skin. Electrodes are the sticky pads that are placed on the body in certain positions. The electrodes allow the electrical activity of the heart to be recorded. The lead wires are wires that are connected to the electrodes, and they transmit or send the heart's electrical activity to the ECG machine. The lead wires are typically color-coded, and they need to go in the correct position. The 10 electrodes create 12 different views of the heart, and the electrical activity of the heart is recorded from those 12 angles. And these 12 views of the heart are the 12 leads you see on the ECG. So a lead is a recording or view of the electrical activity of the heart from the angle of that particular electrode. Some of the electrodes communicate with each other, which is why there are 12 different views or leads from only 10 electrodes. Now that we know the definitions, let's go back to our diagram. So the circles you see are the electrodes, and the colors represent the color of the lead wire that connects to that electrode. But how do you remember where to place all the different electrodes and lead wires? Well, let's walk through a memory trick mnemonic that will help you remember exactly where to place them. Starting with the limb electrodes and lead wires, these are the ones that go on the extremities, and there are 4 of them. First, you're going to remember white on the right. This will help you remember the white lead wire, which is the right arm, goes on the right side. You'll place the electrode on the right arm, typically above the right wrist, and then you'll connect the white wire labeled RA for right arm. Then use clouds over grass to remember white, which is clouds, goes over green, which is grass. We already know the white lead wire is the right arm, so the green lead wire is the right leg. You'll place the electrode on the right leg, typically above the right ankle, and then you'll connect the green wire labeled RL for right leg to that electrode. Next, you'll use smoke over fire to remember black, which is smoke, goes over red, which is fire. The black lead wire is the left arm, and the red lead wire is the left leg. You'll place the left arm electrode on the left arm, typically above the left wrist, and then you'll connect the black wire labeled LA for left arm. You'll place the left leg electrode on the left leg, typically above the left ankle, and then you'll connect the red wire labeled LL for left leg. Again, many people call these limb leads. These are not leads. They're electrodes and lead wires that are used to get the limb leads. The limb leads are what you see on the ECG that are derived from these limb electrodes and lead wires, and they're labeled different on the ECG. I wanted to point out that you may see some literature and studies suggesting that you can put the limb electrodes anywhere on the limbs, as long as both sides are symmetrical with each other. However, studies have suggested changes to the ECG morphology the more proximal the electrodes are placed on the limbs. so make sure to follow your ECG and institutional protocols. Now that we know where to place the limb electrodes and lead wires, let's move on to the precordial electrodes. Remember, these are the ones that are placed on the chest, and there are 6 of them. The lead wires are labeled V1 through V6, and you can use the mnemonic "Ride your green bike on pavement" to remember the order of the colors. The R for ride is to remember V1 is red. The Y for your is to remember V2 is yellow. V3 is green. V4 is blue. V5 is orange. And V6 is purple. There's also another memory trick you can use, so keep watching. But first, let's look at exactly where to place the precordial electrodes. This is important, so don't skip it. Starting with V1, you're going to place the electrode in the 4th intercostal space right of the sternum. You'll then connect the red lead wire labeled V1. Use ride in the mnemonic to remember V1 is red. Remember, the left leg was also red, so make sure to always check the lead wire labels. Next is V2. You'll place the electrode in the 4th intercostal space left of the sternum. You'll then connect the yellow lead wire labeled V2. Use your in the mnemonic to remember V2 is yellow. Let's skip V3 and go to V4. You'll see why in a minute. You'll place the electrode in the 5th intercostal space mid-clavicular line. You'll then connect the blue lead wire labeled V4. Use bike in the mnemonic to remember V4 is blue. Now let's go back to V3. You'll place the electrode midway between V2 and V4. You'll then connect the green lead wire labeled V3. Use green in the mnemonic to remember V3 is green.
Managing schizophrenia with daily pills is a constant reminder of your condition.
Moving on to V5, you'll place the electrode in the 5th intercostal space anterior axillary line. You'll then connect the orange lead wire labeled V5. Use on in the mnemonic to remember V5 is orange. Finally, we have V6. You'll place the electrode in the 5th intercostal space mid-axillary line. You'll then connect the purple lead wire labeled V6. Use pavement in the mnemonic to remember V6 is purple. Here is one more memory trick you can use. First, you're going to use the colors of a traffic light to remember V1 through V3. V1 is red, V2 is yellow, and V3 is green. Then use the mnemonic BOP to remember B is for the blue V4, O is for the orange V5, and P is for the purple V6. I also wanted to make you aware of a modified version of electrode placement. You may see some literature placing the limb electrodes on the torso like shown in the picture. This may be necessary if someone has an amputated extremity or to reduce motion artifact if the limbs are moving a lot. Just know that studies have suggested potential significant changes to ECG morphology when the limb electrodes are placed on the torso. So if the limb electrodes are placed on the torso, it's good to notify the provider by writing torso position limbs on the ECG. Again, remember to follow ECG and institutional placement protocols. Here is a summary table reviewing everything. Remember, a 12-lead ECG uses 10 electrodes and 10 lead wires. 4 electrodes are placed on the limbs, and the limb lead wires that connect to these electrodes can be remembered using white on the right, clouds over grass, and smoke over fire. The lead wire for the right arm is white, the lead wire for the right leg is green, the lead wire for the left arm is black, and the lead wire for the left leg is red. 6 electrodes are placed on the chest, called precordial electrodes, and the precordial lead wires that connect to these electrodes can be remembered using the mnemonic "Ride your green bike on pavement." V1 is placed in the 4th intercostal space right of the sternum, and it's red. V2 is placed in the 4th intercostal space left of the sternum, and it's yellow. V3 is placed between V2 and V4, and it's green. V4 is placed in the 5th intercostal space mid-clavicular line, and it's blue. V5 is placed in the 5th intercostal space anterior axillary line, and it's orange. V6 is placed in the 5th intercostal space mid-axillary line, and it's purple. Hopefully this helped you understand how to place a 12-lead ECG.
All right, so that's your 12 lead. That one was a little lengthy, I'm sorry, but it had good information. And then this will put it into perspective for you.
An EKG is a simple and painless test that records the electrical activity in the heart. The doctor will use an EKG to detect any heart problems such as a heart attack, irregular heartbeats, or heart failure. With each heartbeat, an electrical signal travels from the top of the heart to the bottom of the heart, causing the heart to contract and pump blood. This signal creates the rhythm of the heartbeat. Okay, I'm going to have you have a seat right up here.
All right.
And today we're going to be doing an electrocardiogram, also known as an EKG. Have you had one of those tests before?
No.
No? Okay. So this test is going to measure the electrical activity in your heart. We'll show how fast your heart is beating, if you have a regular or an irregular pulse, and it'll show us the electrical activity in each part of your heart. There are many reasons why a patient may need an EKG. Your doctor will normally order one as part of your routine physical. If you were to complain of chest pain, an irregular heartbeat, or a fluttering in your chest, if you were to have shortness of breath, weakness, fatigue, your doctor may also order an EKG at that time. There may be also other reasons, such as a strong family history of heart disease with your mother, father, sister, or brother. Your doctor may also order an EKG if you are on heart medications or have a pacemaker. So we're going to go ahead and get started on your EKG. I'm going to have you lie back, and I'm going to bring this out for your legs. All right, and just relax. Are you comfortable lying like that for a few minutes?
Yes.
Okay, I'm going to have you undo your gown so I can see your chest. I'm going to place electrodes across your chest, on your arms, and on your legs. The electrodes are just small, sticky tabs that'll be placed over your body. Sometimes when men have a lot of hair on their chest, we will need to remove that hair so that the adhesive sticks better to the skin. There are about 10 to 12 electrodes on normal EKGs. I'm going to roll up your pant leg just a little bit, okay?
Yes.
Okay, just relax. Now I'm going to take these leads and hook them to the electrodes. That's what's going to create that electrical activity to show up on my EKG machine. And it'll show up on a grid on the piece of paper, or it can also show up on a screen for the doctor to read.
All right.
Okay, I need you to lie real still. Try not to move too much and try not to talk. This will just take a couple seconds. Okay, that was it. Now I'm just going to remove these leads and the electrodes. I won't be able to give you any results. You will need to follow up with your doctor, and he'll be able to go over those results with you.
All right, thank you.
All right, so that just kind of gives you a real life perspective on how the EKG is done. And that is the end of our cardiac assessment lecture. But to piggyback off of this, we also need to talk about peripheral vascular assessment because they're kind of one and the same. We do them at the same time. So we're going to go back to our modules. And we're going to go back down to Module 3. And this is a lot of the stuff that we've already talked about, and a lot of it's common sense. So this part goes really fast. So down there in week 7, we have also peripheral vascular lecture notes, so you can go ahead and click on that. And I'm going to download that for y'all so it'll be easier to see. Now, maybe not. We'll just roll with this. But y'all can print it out and y'all can look on y'all's slide as well. So let's just kind of roll with this. Peripheral vascular assessment. So this is going to come from your Essential Health Assessment book, Chapter 15, which starts on page 261 and goes through page 279. The peripheral vascular system is what you're seeing on your screen here. These are just your arteries and your veins that carry that oxygenated and deoxygenated blood through your circulatory system. And your lymphatic system is also part of the peripheral vascular system, but it carries that lymph fluid through your circulation. So that's the different anatomy pieces that you see there that we're going to be talking about. All right, so let's talk about arteries first. So with our arteries, these carry our freshly oxygenated blood, like we've already talked about. The exception to that, of course, is our pulmonary artery. You have these arteries that have a pressure wave through them. But these pressure waves can only be felt at sites where that artery lies close to the skin and it's over a bone. So that is how you can find a pulse, is by feeling one of these pressure waves through an artery. We're also going to be talking about the different types of pulses, and I'm fixing to show you a picture, but you need to be able to locate each one of these pulses. These pulses right here, we have the temporal artery, which we talked about in the HENT lecture. Facial artery, we did not talk about. That is not palpated much, but you still need to know where that artery is. Common carotid artery, we just talked about that one. Remember, we're going to palpate that unilaterally. Brachial artery, y'all should be good with those by now. After doing those 2-step blood pressures, y'all know all about the brachial artery as well as the radial artery, because y'all was doing manual pulses whenever we did pulses and heart rates during vital signs. Femoral artery, that is one that you're going to want to get used to knowing where it's at and how to assess it. If we're ever doing CPR and somebody asks you to feel for a pulse, they want you to feel one of those central pulses. So carotid or femoral. Don't reach for a radial pulse if they're asking you to get a pulse whenever they're doing CPR, because you may not get a strong enough surge of power to go through there. But we should at least be perfusing that central core of the body. Popliteal pulse, that's usually kind of harder to feel, so a lot of times we bypass that popliteal pulse and we'll go straight to the dorsalis pedis. If you have a dorsalis pedis pulse, then you definitely have a popliteal pulse. I put 2 pictures over here because a lot of the times students get confused with the posterior tibial and that dorsalis pedis. With the posterior tibial, you'll look right here. A lot of people think it's on the ankle side or the outside. That pulse is actually on the inside part of the top part of the foot there. So you can see it's on the inside part of the leg on the side. Your dorsalis pedis pulse sometimes is a little bit difficult to find until you really know what you're looking for, but it's going to be right along the line in between that great big toe and your first toe, so right along here. So really be comfortable with knowing where those pulse sites are and be confident in your palpating of those pulses. Now, we do grade pulses on a grading scale of 0 to 4 plus. 0 means that pulses are absent. That means there's none there. We don't feel them. This can be from decreased circulation. It could be from edema. There's a number of reasons. But if you're saying that the pulses are absent, then you're going to want to use a Doppler, and I'll show you what a Doppler is in just a minute, before you make a definite decision of a grade 0 pulse. So we want to be absolutely sure that it's grade 0 before we declare it grade 0. 1 plus would be a thready or a weak pulse. 2 plus is a normal pulse. 3 plus is a strong pulse. And then 4 plus is a bounding pulse. This picture just kind of should refresh your memory of the different arteries in the arms. And we also have a picture of the different arteries in the legs here. So you can go back and review that if that does not look familiar. Ischemia. Okay, so whenever we have an arterial issue, if we have a deficient supply of that good, rich oxygen arterial blood getting to the tissues, then we will have ischemia develop. Okay, this causes pain to our patient. This causes dysfunction, and it can even cause necrosis and death to that tissue from lack of oxygen. Okay, a lot of the times it's going to be caused by an obstruction to the vessel or to the artery, and that blood flow just does not get to that place, so it can't thrive and it can't live, and it just eventually gets necrotic, and there's tissue death from that, from not being able to get the oxygen that it needs. Once it gets to this point, that is irreversible. It's not coming back, so a lot of the times we do have to amputate that or cut that off. If you don't, then it's going to develop into gangrene, and it'll just get worse and worse until it causes more issues. So we would definitely cut off the dead tissue. Arterial issues start at the periphery. They usually start at the toes, like the tips of the toes, furthest away. And if you can't restore this blood flow pretty quickly, then you will no longer have a foot there. This just kind of shows what happens when necrosis occurs. All right, and then we have the veins. The veins, they run parallel to our arteries, but they're closer to the skin, so that's the reason why you see these better. And they drain this deoxygenated blood back to the heart and its waste products from the tissues that come along with it, and they return it to the right heart. Something very important that you want to note about veins is that veins do not have a pulse. So y'all are going to be starting IVs pretty soon after you start a second semester. And just as a word of advice, you're sticking veins. So if you're about to stick something and it has a pulse, that is not a vein, that is an artery. So you want to be very careful to be sticking veins and not arteries. Lymphatic system, that's just kind of like our own little circulatory system that we have. The lymph will drain down. Our job of the lymphatic system is to produce white blood cells. It's to balance that fluid and that protein, and it's also used for immunity and to help reduce the spread of infection. This is what a normal lymphatic system looks like and how it operates. So that just kind of needs to be in the back of your mind as we talk about assessment of this and the different issues. Lymphatic ducts and drainage patterns, just keep in mind that these drain down. Some related organs in our immune system, you have the spleen, which helps filter our blood. We also have the tonsils, which is our initial line of defense against infection. You've got the thymus gland that produces our lymphocytes. You've got those Pyre patches that you see up there. That's those little raised clusters of lymphoid tissue that's in our small intestine. And then you have the bone marrow that produces our lymphocytes. So these are all the organs that kind of contain that lymphatic tissue. Some lymph nodes that were not covered in the head and neck section that we did earlier on in the semester would be these inguinal nodes, these axillary nodes, and epitrochlear nodes. A lot of the times we have to keep an eye on this, especially in different cancers like breast cancers. If you have the breast removed, not only do they take out the breast, they also take out, a lymph node or two to ensure that the cancer hasn't spread. And if a lot of lymph nodes are removed, then that could affect the drainage pattern of the lymph nodes, and it can cause a backup of fluid known as lymphedema. This is actual swelling. It's not the pitting type of edema that we talked about earlier. It's just on the side of the lymph nodes that were removed normally. So it would just look really big and swollen. And here's a picture of a patient with lymphedema. So you obviously want to ask if this is not, if you try to pit it and it doesn't pit, you want to ask the patient, have you had any lymph nodes removed? Have you had any issues with your lymphatic system if you see a patient like that? Capillaries and fluid exchange, go back and review this if it's not ringing a bell. Review of systems, we have our health history, past medical history. I'm asking about things like heart disease, any history of stroke, diabetes, increased blood pressure. All of these have an increased risk for developing peripheral artery disease. I'm asking about any history of increased cholesterol. Is my patient overweight? Because an increase in body fat is going to increase that risk of fat buildup in the arteries. Family history, I'm asking about all those questions as well. Psychosocial history, do you have a job where you sit for prolonged time? Do you travel for long periods? Do you exercise? How often do you exercise? And you're asking those types of questions because the less mobile patients are, that increases their risk of those blood clots and that decreased venous return. Also ask your patient if they smoke. That vasoconstriction from nicotine can also affect the vessels there. Medications, I'm asking specifically about blood thinners, cholesterol meds, oral contraceptives. All of those increase the risk for different bleeding issues or clots. And the current health status, of course, all of these I'm going to be going into my old charts with. Inspection and palpation of the cardiovascular system. Overall view of skin color. We know that gray or that bluish color of the skin means decreased oxygenation. Hair distribution, that uneven hair distribution could be the first sign of an arterial issue. So we want to make sure that that's even. Edema, we've already talked about that. Abnormal pulsations, we've already talked about that. Capillary refill time, we've already talked about that as well. Palpating those pulses, we've already talked about those as well. And just change that on your slide. That should say 0 to 4 plus, not 0 to 3 plus. And then we're also checking for things like thrills and Holman sign. And Holman sign is just where you dorsiflex the foot and you're looking to see whether or not the patient has pain in their calf. A lot of the times that is associated with a blood clot if they come in with other symptoms as well. They would still need an ultrasound done to confirm, but you may be asked to do the Holman sign, or you may see that documented sometimes. It's not used as much anymore because it's only been proven to be accurate about 30% of the time, but you still may see it done. Okay, the ALIDS test, that just assesses the patency and how well that ulnar artery and radial artery is working. And you can do this little test on whoever you want to at home. This is pretty cool. You just kind of press down on that radial artery, which occludes it. Have the person open and close the fist, and their hands should be pretty much white because you're not letting any blood flow through it. And normal would be that whenever you let go of one side or the other, that the pink should fill up in the hand to signify that blood flow came back. And that would mean that the ulnar artery and radial artery is patent. All right, Raynaud's syndrome. This is also called Raynaud's phenomenon or Raynaud's disease. This comes and goes. It's little ischemic attacks of the extremities, and it's where you have a bilateral response to things like cold, vibration, or stress. The different stages that it goes through. First, the affected extremity turns white, so that's the little spasm in the artery going on. Second, it turns blue, and that's the spasm just relaxing. And then third, it turns red, and that's the return of blood to the capillaries. These patients complain of things like numbness, tingling, pain, and then color and sensation is restored with heat. And here is a picture of a patient that has Raynaud's. All right. We're also going to inspect the legs whenever we're inspecting peripheral vascular. Both legs should be the same size symmetrically without swelling or any type of atrophy going on, or we may need to measure the calf muscle. If you do that, you're going to want to do it at the largest point in both the legs. And if you have a unilateral swelling, you kind of want to raise your red flag up that maybe you may have a local problem like a DVT. Any type of asymmetry of the calves greater than 1 centimeter is considered abnormal, and you do want to get that checked out. You want to make sure whenever you measure that it's at the same place on both legs. You want to make sure if there's any type of unilateral swelling like this that you do not massage, because we don't want to break a clot loose and it travel to the lungs. All right, this shows us a little picture of something called a varicose veins. So sometimes a vein just can't handle the gravity and the increased pressure over time, and it starts to bulge out. And when that happens, you get this thing called a varicose vein. Compression hose can help prevent these, but these become painful, and it's usually associated with occupations where you stand for long periods of time. It's a nice little picture of a varicose vein there. All right, we're also going to be palpating the legs for temperature. So we're going to want to use the dorsal side of our hands, and it should be the same. Any type of unilateral coolness can be associated with arterial insufficiency. Any spot that's really warm unilaterally with swelling could be indication of a DVT or a deep vein thrombosis. Inspecting and palpating, we are seeing if the patient has any leg pain or cramps, specifically whenever they're walking a certain distance. If that's when the pain starts, that's called claudication. That's cramping with activity. If this happens, you do want to record the number of blocks or the stairs that it takes to produce the pain, so you can kind of figure out ways to control it. We're also looking for swelling. If we notice swelling bilaterally, that could be something associated with congestive heart failure. If it's unilaterally, we're thinking something local like a DVT. Skin color changes that we may see with the veins, that brown discoloration, that's going to occur whenever we have a long-term vein problem where blood is just sitting there pooling. It's those little iron deposits that gives it that brown color. Your venous stasis ulcers, that's going to be around the medial malleolus, which is around the ankle area. And the difference in how you can tell usually your arterial issues versus your venous issues is a lot of the times the arterial issues are going to start at the tips of the toes, the tips of the fingers. Your venous is going to occur usually around the ankle. Is where it's going to start out, and then it'll go up the leg. All right, so this is just an example of a venous issue. This would be an example of a venous issue that actually resulted in an ulcer. That would be an example of an arterial issue, because you see it's at the tips of the toes. All right, palpating. Holman sign, we already kind of talked about that. It has that calf pain with dorsiflexion, could be due to a DVT. We want to make sure that we do not squeeze or massage the calf of anybody that has a suspected DVT. We're going to be palpating and grading the pulses, and we're also going to be checking to see whether that edema pits or not. Deep vein thrombosis, that's just where a deep vein has been occluded by some sort of thrombus or clot. Usually it's a very sudden onset, and we already talked about the Holman sign and the risk for pulmonary embolism, so we don't want that clot to travel and go to our lungs. Lymphedema, damage or removal of the lymph nodes impedes that drainage of the lymph. There's unilateral swelling, it's non-pitting. Here's another picture of lymphedema. Can't talk about peripheral vascular and not just touch a little bit on aneurysm. You will get this in a later curriculum, but this is just a little weak place in the vessel that balloons out, and that's not the issue. The issue is if it ruptures. So we want to make sure we do everything that we can to prevent it from rupturing. High blood pressure is usually a big cause of it rupturing because that increases the pressure on that weakened area. So we want to make sure we do everything that we can to keep that blood pressure low. Treatment, we may operate on it. If it can't be operated, we may put a little coil in. And then, of course, we're going to put this patient on blood pressure medicines to keep that blood pressure as low as possible. So this can be lethal. So if no mesh is put on it and it ruptures most of the time, you can't get them to the OR fast enough. These are just some different places where you could have some arterial occlusions and aneurysms happen in the body. And this is that picture of a Doppler that I was telling you about earlier to assess the pulse. All right, well, that is your cardiac assessment and peripheral vascular assessment lecture. Don't forget to check on Monday in your labs module for week 7. So you'll know what all you need to bring to lab this week and any documents that you need to print out or whatever, so you can know that ahead of time. And we will see you in lab this week on your designated lab day.